So, dear colleagues, we are starting our session number 5, RWE, RWD, in the system of care for rare disease patients. It is a session in the framework of the 3rd Orphan Forum of CIS/BRICS countries, and we will be working from 4 p.m. to 6 p.m. Moscow time. My name is Alexei Kolbin, medical doctor, professor, head of the chair for clinical pharmacology and evidence-based medicine in the first St. Petersburg Medical University, and I'm also head of the project on building up RWE, RWD concept as part of CIS, Eurasian Economic Union countries, and I was delegated the authority to be the moderator of this session. This session will be focused on state-of-the-art approaches to real-world data, RWE, RWD, for rare disorders. And the discussion will be centered on observational studies, application of the RWE, RWD in regulatory processes, in healthcare technology assessment, expert decisions, clinical decisions, and we will also discuss with you approaches to quality assurance, data quality assurance, discuss international experience of the use of RWE, RWD data to improve the groundness and justification provision for rare diseases. 7 presentations altogether will be made, and I would like to ask the speakers to stick to the timing, 15 minutes for presentation. If there are questions, we will be asking them to the speakers. It will be conducted with simultaneous translation from Russian to English and from English to Russian. And now let us start with our first speaker, David Danko, managing partner in Ideas and Solutions, Hungary. And the presentation will be about the approaches to benefit financing for orphan drugs, a model for European Union. Thank you very much. The floor is yours.
Thank you very much. And thank you very much, Alexei Sergeyevich. I am very happy to be today here with you. And I used to work as Deputy Director of Reimbursement in my home country, Hungary. And currently I am Managing Director of Ideas and Solutions. I will share my screen. So my presentation today is about approaches to the preferential funding of orphan medicines, and I would like to give a couple of examples from Europe, including policies and practical applications. For orphan medicines, I think there are a couple of important questions in terms of policy design. It's a usual problem that we have many priorities, but we don't have sufficient resources. So the first question is always whether a differentiated funding of orphan medicines is in alignment with health policy in general. It's common for health policy to pay special attention to vulnerable populations, but it's uncommon to have sufficient funds. So we have seen cases where orphan policies compete with pediatric policies, cancer policies, and policies priorities about severe debilitating diseases, for example. The second question is whether we want to prioritize orphan medicines in general, or we would like to prioritize rare diseases. The first one is regulatory designation, orphan medicines, whereas the second one is generally an incidence or prevalence-based classification. From a payer perspective, I think it's very important to differentiate between orphans and ultra-orphan medicines. The regulatory definition of orphans, which is less than 5 in 10,000, is not necessarily something which is easy for payers to implement, for funders to implement. In some countries, I think payers have a higher willingness to prioritize ultra-orphan medicines where, however, there is no exact threshold. The UK, for example, uses less than 1 in 50,000 in terms of prevalence. The final thing I wanted to mention here is that when it comes to payer attitudes to orphan medicines, we may see sometimes a differentiation between oncology and non-oncology. And my impression is that this is partly due to the fragmentation of indications in oncology. From a payer perspective, again, it's very hard to follow on the number of indications, on the new mutation-specific or biomarker-selected populations, and to consider them orphan indications the same way as a pediatric orphan indication can be considered. Having said that, I believe that there are 5 key areas in which policymakers and payers can prioritize or do prioritize orphan medicines. The first is tax and clawback waivers, so some kind of reductions, some kind of exemptions from pharma taxes. The second is preferential treatment in health technology assessment processes. The third is dedicated in our HTA jargon, ring-fenced budgets. The fourth is early access pathways or accelerated access. And number 5 is patient registries and real-world evidence tools. I would like to give a couple of examples for each of these, but given the time constraints, this is going to be quite a superficial overview and just food for thought. That's the intention here about each bucket, about each category. Waivers and reductions from pharma tax, clawbacks, and payback obligations. You know that governments usually or very frequently impose mandatory discounts, rebates, clawbacks, and industry taxes, mostly on innovative medicines, typically patent-protected products. For orphan drugs, these policy tools can be detrimental as they disincentivize access to these medicines. So one strategy or one possibility is for policymakers and payers is to offer some kind of exemptions, waivers, to remove or to reduce these obligations, tax obligations, clawback obligations on orphan medicines. There are a couple of related policy tools which I have already referred to: exemption from turnover tax, partial or full exclusion from mandatory payback and clawback schemes, reduced or zero rebate rates, and it's an interesting way of managing the same problem, but let's say exemptions or waivers from HTA-related fees. And I have brought here a couple of examples from Belgium, France, Italy, Spain, UK. So it can be seen that a couple of major European markets do use such techniques. Belgium, for example, offers full exemption from clawbacks and industry tax. And Spain, just to name another one, provides for lower mandatory rebates, applicable to orphan drugs versus the standard medicines. When it comes to the preferential treatment of orphan medicines, then the objective and the policy goal here is again, I think, pretty clear. In cost effectiveness based systems where cost per quality thresholds are used, these thresholds are usually not met by orphan drugs, which would mean, again, a negative incentive for these products. So as a way to counteract these negative incentives, preferential HTA rules or regulations can be applied to orphan drugs. For example, higher willingness to pay thresholds, or presuming added benefit without a active comparator, like in Germany, or supplementing the ICER logic, so the cost per quality logic, via some kind of multi-criteria scoring. And again, you see the logic here, or the key point here, is to bring extra additional flexibility into the system and to move away from that rigidity which sometimes characterizes cost per quality thresholds. A couple of examples here. England, through its very narrow niche but important highly specialized technologies program, applies a higher threshold, a much higher quality threshold for these technologies which qualify for having this HST, highly specialized status. Germany assumes added benefit for all orphan drugs, even if the direct comparator is missing, and interestingly, it sets a budget impact limit for this type of qualification. And Czechia from the Central European region uses a 10 criterion MCDA, so multi-criteria type of system for the analysis, for the assessment of orphan drugs. If we move on towards the third possibility, or let's say strategy, which is dedicated funding, ring-fenced budgets, then again the policy thought here, the motivation here, is to bring some kind of extra flexibility into the system. Orphan drugs can put some kind of unsustainable financial burden on regular pharmaceutical budgets. So ring-fenced budgets provide an alleviation for that pressure. They provide an extra type of funding for these type of technologies. And even more importantly, these budgets, these ring-fenced funds, can accommodate technologies with a lower evidence base. So it can be seen as a temporary entry mechanism, and there are a couple of such funds which are pretty famous. In the United Kingdom, the Cancer Drug Fund. In Italy, the innovativeness funds for oncology and non-oncology medicines. In Belgium, the Special Solidarity Fund, or partly related to this topic, in France, the so-called liste en sus system, whereby high-value hospital medicines are exempted, are carved out from the DRG system, so they are not financed through the DRG system. If we move on, then the fourth category is early access pathways for orphan medicines. As I have just mentioned, related to the ring-fence budgets, the evidence base or the evidence accompanying orphan medicines can be limited compared to what normally payers expect, and I'm especially referring to overall survival data or active comparisons or data maturity. So there is always a possibility to offer some kind of extra flexibility to orphan drugs in terms of what evidence is requested or what evidence is necessary and sufficient, and to give patients an opportunity to receive these drugs while the regular reimbursement process, the regular decision process, is ongoing. In France, there is a very famous early authorization system, AAP, In Italy, there are more limited opportunities, but they do exist. In Scotland, ultra-orphan medicines get automatic 3-year access while evidence is gathered. And I have brought a couple of other examples, so Czechia and Portugal. The message here, or I think the general picture here, is that such early access type of mechanisms are pretty widespread. And finally, we arrive at the narrower topic of this session: patient registries, real-world evidence generation. I can only repeat the problem. Orphan drug approvals are often based on small trials, limited evidence, surrogate endpoints, short follow-up. So it's a very rational kind of sandboxing opportunity to offer some kind of conditional access to these systems accompanied by patient registries. These fill the evidence gap while patients can get treatment, and they also create some kind of accountability or protection mechanisms which offer payers protection against huge budget impact. Italy is famous for these, so the IFA registries. Netherlands uses registries for supporting conditional reimbursement, which is, I think, a very important and interesting option. My country, Hungary, in the hospital funding system, uses detailed case report forms linked to reimbursement protocols or reimbursement limits, whereby data is gathered and treatments are authorized by the payer. As I have a couple of conclusions, as I have mentioned, if general rules apply to orphan drugs, it usually means a huge disincentive. So when a general system is designed, it's quite common that exemptions, preferential mechanisms for orphan medicines are also designed. I think the key problem is evidence gaps from an HTA perspective and less of a budget impact problem. Perhaps I'm contradicting myself, but I think there is an important distinction. From an HTA perspective, limited evidence is the problem. From a payer perspective, budget impact is the problem, which is exacerbated by limited evidence when we don't know what we are supposed to reimburse. The other thing is that I do like early access or this type of provisional reimbursement schemes, like I have just mentioned the Netherlands. But there is an important condition here. The payer should be able to say no at the end of the trial period. And this is a very common concern by payers, that they won't have the opportunity to take a negative decision if the evidence generation period shows that the drug falls behind the expectations. So I think that registries are a must to meet this condition. Registries enable these decisions, and without registries, the payer concerned that they won't be able to have a negative type of judgment or assessment, these concerns are real. So registries are a must in order to support this type of logic. The third type of conclusion is that across Europe, Italy is said to have the most extensive system of patient registries, and it is true, but data quality is fluctuating. So in Italy, there are good registries and there are less good, it means worse registries. And I think the usual rule applies, that the smaller an indication and the less the dependence on prescribers, the better can be data quality. Prescribers, healthcare professionals often do not like the administrative burden, the data burden which registries then generate for them. And the final point I would like to mention is that, as most of you likely know, the European Union Joint Clinical Assessment Regulation will be applicable to orphan medicine starting in 2028. So in two years now, countries will share the clinical reviews and negotiate and do the health economic part and negotiate prices independently of each other separately. So real-world evidence collected under national coverage with evidence development schemes is going to feed into this process. This means that I personally believe that the importance and the quality of registries will increase or improve following the JCA implementation. Thank you very much for your attention.
Thank you very much, David. And I wrote a question. I wrote down a question that I wanted to ask you about joint clinical assessment, but your fourth conclusion was the answer to my question, actually.
I'm pleased
So
to hear.
Hungary does participate in this project?
Yes, definitely. This is a broad and interesting topic. We still do not know how much JCA will eventually help the smaller countries, but I am optimistic because the quality of clinical assessment in smaller European countries, due to the lack of resources, is let's say not necessarily perfect. So if we get a sound assessment and we can focus on the localization and on the health economic part, I think it will release some kind of capacities, and it will help improve the quality of assessments in general. But I think we will be able to revisit this topic in 2 to 3 years from now.
Yes, there is the first conclusion available already for a cancer drug, if I'm not mistaken.
Yes.
It was done in Ireland, I think.
Yes, exactly. So I'm not an expert on the JCA details, but cancer drugs undergo already mandatory joint clinical assessment, and essentially national HTA agencies are what's the reference of each assessment, and this is also an important thing that the quality of the national institutions, due to this type of ownership process, it's expected to equalize, because we cannot afford in bracket or in quotation marks, we cannot afford to lead a poor project if other projects have proven to be very successful and very high quality.
Thank you very much. It was extremely useful and valuable presentation for us. Thank you ever so much indeed. So now, dear colleagues, we are moving to further implementation of our agenda. Our second speaker is from Brazil, Frederico Salum, who will tell us about the role of real-world data, real-world evidence in justification of healthcare technology for rare diseases. In fact, it is a follow-up to the first presentation with subsequent developments. Thank you. The floor is yours.
Hello, everyone. Thank you for the opportunity. I will share my screen to start the presentation. Okay, so again, thank you very much for the invitation. Today, I would like to share a Brazilian perspective on how real-world evidence may support healthcare decision-making in rare disease, particularly from an HTA perspective, while also discussing future opportunities and emerging methodological approaches. Before discussing Brazil specifically, it is important to briefly reflect on how real-world evidence matters in rare disease. So talking a little bit about of me, I currently lead real-world evidence, HEOR, pricing, and health innovation activities at CIES Brazil. My background is in health economics, with research interest in multi-criteria decision analysis and evidence generation in healthcare. Let's briefly discuss the role of real-world evidence in rare diseases. First, I will briefly discuss why RWE matters in rare disease. Then I will share a Brazilian perspective, followed by future opportunities and some emerging approaches that may enrich healthcare decision-making. Let's start with the context. Sorry. Okay. Sorry, I had a problem with the slides. So rare disease frequently face important evidence limitations, and clinical trials often involve small populations, as the first colleague has said, making evidence generation particularly challenging. And we have small patient populations. This naturally creates uncertainty because patient populations are limited and disease heterogeneity is often high. This is one of the reasons that we need real-world evidence for rare disease. So the need for long-term outcomes, and in many rare disease, long-term outcomes are specifically important, but difficult to fully capture through traditional clinical outcomes alone. So this is where real-world evidence may play an important additional role. So what does this look like in Brazil? Let's talk about the Brazilian perspective. So, Brazilian already has a national policy framework for rare disease. This is a very good achievement to us, which recognizes the coordinated care and the importance of structured pathways for patients. This is very important because we have comprehensive care guidelines for rare patients in Brazil. So this is I would like to highlight here from Brazil. And we have an important national healthcare database. That is DataSUS. SUS is an acronym that stands for Unified Healthcare System, from our public healthcare system perspective. And about multi-stakeholder engagement, it's a very very important for rare disease, the collaboration among policymakers, healthcare professionals, patient organization, and other stakeholders is already part of the Brazilian rare disease involvement. It's another important part that I would like to highlight here to you all. And opportunities for evidence generation. We have many opportunities and we need to reach this more and more. And we need to enrich this more and more. And talking about future opportunities, strengthening rare disease registries. This is very important. Patients' registries may help improve disease understanding and longitudinal evidence. This is what I've been trying to enrich in Brazil. Greater integration on healthcare data. So further integration of healthcare data may strengthen evidence quality over time. And as I said, it's very, very important for rare disease due to many reasons. Advancing the use of real-world evidence, because real-world evidence may increasingly complement traditional evidence in future healthcare decision-making. So this is very, very, very an important point again. And so Brazil already has important foundations with opportunities for further evaluation. This is the landscape that I would like to highlight to you all about Brazil here. So looking ahead, where could real-world evidence contribute even more? So I said you that that we need real-world evidence for rare disease due to main topics. So, and what we can achieve with that for rare disease? Reducing uncertainty in HTA. Real-world evidence may help reduce uncertainty, specifically in settings where traditional evidence is limited. It was already discussed here. Monitoring real-world evidence. Real-world evidence may support understanding how treatments perform in clinical practice, informing sustainable healthcare decisions. This may help balance patients' needs and healthcare system sustainability. Innovative access approaches. In selected situations, RWE may also support innovative approaches to access. So, beyond data itself, methodology may also play an important role. So I would like to share with you some emerging approaches and that I personally I have been trying and using in some of my projects in order to generate more evidence and to clarify more the clinical rare conditions in rare disease. So as already discussed here in this forum, MCDA, multiple criteria decision analysis, has additional methods such as that can help structure complex decision under uncertainties, because we can select, order, or analyze a set of alternatives according to their performances on a set of criteria. Because rare disease challenge our conventional health economics methods. So we need to bring more criteria to the decision making. So according to many of the international guidelines, when I'm using specific outcomes, just like quality, we cannot consider under the decision-making process some specific, I cannot use in the conventional economic model criteria that are important for rare disease, just like caregiver costs, the burden of disease, once I'm using quality and as my main outcome. So multiple criteria decision analysis, we have the chance to analyze the full complex scenario, the full situation, in order to analyze better and evaluate the health interventions for rare disease. I would like to highlight two cause-effect relationships or cause-effect inference between clinical parameters. This can support us a lot in understanding the clinical conditionals, how clinical conditionals is associated in rare disease. And we have some multiple criteria decision analysis methods that uses the concept of cause-effect relationships, cause-effect inference, just like DiMattel method and Wings method. I would like only to highlight the name of the methods, and I think that we need to use it more and more in order to analyze more cause-effect between clinical conditions, clinical parameters in rare disease. And real-world evidence-enabled reassessment. I think that decision-making may increasingly evolve towards continuous learning rather than one-time assessment. So in rare disease, better decision may depend not only more evidence, but also on better ways to structure complexity. And here are my takeaways. I think the first one, rare disease require adaptive evidence approaches. Real-world evidence may support better informed healthcare decisions. and methodological innovation may further enrich future decision maker. So thank you very much, and I look forward to the discussion. Thank you again.
Thank you very much. Thank you very much, Frederico. I have a quick question. In Brazil, do you have you have a national program, a kind of national concept, maybe? Do you have a kind of national level document like FDA, similar to FDA, for example, of what is real world evidence, real world data, how do they work, where they must be applied, some kind of framework document? Do you have a kind of document like that, or you use some expert conclusions, some international documents? So what is your current situation?
Yes, thank you for the question. We have a lot of publications here using real-world evidence in Brazil, and with the opinion of many experts using it here, not only for rare disease, but in many other therapeutic areas. So real-world evidence has been studied here, but I think that for the case of rare disease, we need to use more methods, study more, to use MCDA and use more, study more cause-effect relationship. But yes, we have many publications recommending how to use real-world evidence here.
Thank you. Thank you.
Thank you.
Thank you very much. So, dear colleagues, we are moving further on our agenda, and presentation number 3 is from Larisa Gavrilenko, professor of the Chair of Clinical Pharmacology of Belarusian State Medical University, chairman of the board of Medical Association, Clinical Pharmacology and Therapy, senior editor of International Scientific and Practical Journal for General Practitioners and Family Doctors, RISIP, Republic of Belarus.
Уважаемые коллеги, добрый день. Позвольте познакомить вас с некоторыми аспектами организационных технологий и реальной клинической практики для орфанных заболеваний в Республике Беларусь. Меня зовут Лариса Николаевна Гавриленко, я работаю на кафедре клинической фармакологии Белорусского государственного медицинского университета и являюсь председателем общественного медицинского объединения «Клиническая фармакология и терапия». В соответствии с законом об обращении лекарственных средств, орфанные заболевания – это тяжелые хронические прогрессирующие заболевания, имеющие, как правило, генетическую природу и уровень распространенности в популяции не более одного случая на 10 тысяч пациентов. В нашей стране создана инструкция о порядке формирования перечня орфанных редких заболеваний, инструкция о порядке формирования перечня орфанных препаратов и, собственно, сами перечни орфанных заболеваний и орфанных препаратов. Предложение по внесению заболеваний в перечень орфанных редких заболеваний подается в Министерство здравоохранения с обоснованием характеристики заболевания, патогенетического лечения, эффективности проводимой имеющей место терапии, клинические исследования, опыт применения, число пациентов с данным заболеванием от специалистов, которые занимаются диагностикой и лечением орфанных заболеваний. Но первым этапом организационной технологии доступа лекарственных препаратов пациентам с орфанной патологией является, естественно, регистрация, вывод на рынок. Так вот, для орфанных лекарственных препаратов предусмотрена регистрация препарата как стратегически важного лекарственного препарата. В 2021 году постановлением Совета Министров утвержден перечень стратегически важных лекарственных препаратов, куда, вне зависимости от кода АТХ, входят региональные лекарственные препараты и орфанные препараты. Для них предусмотрена и национальная регистрация регистрация
we
и
have both
регистрация
national
в
registration
соответствии с правилами
and
ЕАЭС,
registration
ну а также
according
внедрена
to Eurasian
упрощенная
Union
процедура
rules and
регистрации
also a
для препаратов,
simplified
которые
registration
зарегистрированы
procedure
в странах с
for the
жесткой
drugs
регуляторной
that are
системой
registered
или
in the
ЕМА.
countries with
Нужно
stringent
сказать, что
regulatory system
сам по
or
себе
EMEA
приказ о
countries.
перечне орфанных заболеваний,
The
орфанных препаратов
decree
еще
of
не
the
дает
list of
возможности
orphan drugs
доступа
is
пациентов
not
к
yet a
лекарственным
sufficient
препаратам.
ground
Именно
to provide
постановление
access
Совета
to these
министров
drugs.
Республики
It
Беларусь
is the decree
и
of the Council of
утверждает
Ministers of
перечень
Republic
тех
of Belarus
заболеваний,
that
которые
actually
дают право
the list
гражданам на
of
бесплатное
the
обеспечение
diseases
лекарственными
which
средствами.
delegates
Этот
patients the
документ,
right to have
постановление
a free
Совета
of
министров в
charge
декабре
access to the
2025
drugs.
года был
This is the
обновлен и
decree of the
вступил в силу
Council
в
of
апреле
Ministers that
текущего
was
года.
updated
В нем
last
установлен
December
перечень
and became
заболеваний,
valid
дающих
this
право
April,
гражданам на
stipulating
бесплатное
the list
лекарственное
of
обеспечение.
diseases
Но для
that provide the
формирования
right
этого
for free
перечня, так же как и для
drugs
формирования
access.
других
But
ограничительных
to build
перечней в
up this
республике,
list as
мы
well as
проводим
other
оценку национальных
limited lists in our country,
фармакоэпидемиологических
we
данных,
perform
клинико-экономических и
evaluation of the national
фармакоэкономических исследований,
pharmacoepidemiological
проводим
data,
оценку реального
clinical studies
потребления
data,
лекарств,
assess
критический
the real
анализ реальной
consumption of
клинической
the drugs,
практики,
critical
а также
analysis
проводим
of the
оценку
real
безопасности и
clinical
переносимости лекарственных средств,
evidence and also
включаемых или
tolerability and
претендующих на
safety of
включение в
these drugs
республиканский формуляр,
that are suggested to
фармакоэкономический
be
анализ
included
стоимости
in the
межелательной
formulary.
реакции,
Also,
смена терапии
pharmacoeconomical
и
analysis
оценка
of a cost
качества
of
лечения.
adverse reaction,
Для
change of
включения
the
в
therapy or
республиканский
evaluation of
формуляр,
the
в том числе
quality of
формуляр
treatment.
для лечения
For
орфанных
the inclusion
заболеваний,
to the
проводится
Republican
клиническая
formulary,
экспертиза, а
we
затем
perform clinical
фармакоэкономическая.
expertise,
На
and
основании
then
экспертных решений
pharmacoeconomical expertise
республиканская
based
формулярная
on
комиссия
expert decisions
рассматривает
with the
соответствующие
Republican
документы
Formulary
и
Commission
принимает решение либо о
examines
включении,
relevant
либо о
documents and
отклонении
gives either
предложения,
positive or
либо об
negative
условном
decision,
включении в формуляр
or
для лечения
sometimes
орфанных
conditional
заболеваний. Формируются планы
authorization.
централизованных
We
закупок,
come up
перечни
with
организаций
the planning for
здравоохранения для
centralized
закупок,
procurement,
клинические
the lists
протоколы
of
диагностики и
healthcare
лечения.
institutions
Одним
for
из
these
важнейших критериев
procurement
принятия
and so on.
республиканской
One of
формулярной
the
комиссии
main
предложений
criteria
о возможности
of
включения препаратов для лечения
positive
орфанных
decision
заболеваний
of the
является
inclusion
наличие
of this
регистра
list is the
персонифицированного
presence
списка
of a
пациентов.
registry of
Потому что сам
personified
факт сбора,
list of
накопления
patient
реальных
names, because the
национальных
very
клинических
fact of
данных
collection,
является важнейшим
accumulation and
критерием
storage
для
of real
принятия
clinical
управленческих
data is
решений и
the
обеспечения
key
пациентов
criteria to
терапией.
take
Вот таким образом
managerial
выглядит
decisions and to
страничка
provide therapy for the patients.
постановления
This is how
Министерства
it looks like,
здравоохранения
this page
26
from
года
the decree
«Лекарственные
of the
средства для
Ministry of
лечения
Council
орфанных редких
2026,
заболеваний», где
drugs
мы
to
видим
treat
международное
orphan and
непатентованное
rare diseases,
наименование
where we
лекарственных
can see
препаратов,
the
лекарственную форму
international
и дозировки, а также
generic
стоимость за
name,
единицу продукта
dosage
за
form
2025
and dosings,
год,
and
предыдущий
then
год. То
we
есть,
have
соответственно, мы здесь
the
видим
results
те
for the previous year.
заболевания,
Therefore,
список,
these
при
are the
которых данные
diseases,
орфанные
the list of
препараты
diseases for
закупаются.
which
В перечень
we
орфанных
actually
заболеваний на
purchase
текущий момент
the
времени в
drugs.
Республике
The
Беларусь
list of
включено
orphan
151
drugs
заболевание. И вот в 2024
currently
году был
includes
включен булезный
151
эпидермолиз.
disease.
Это группа
Bullous
генодерматозов, наследственные
epidermolysis is
моногенные
currently
заболевания, которые
included. This
проявляются в
is a
виде кожных
hereditary
аномалий
monogenous
и часто
disease
ассоциируются с
manifested as
системными
skin
симптомами.
abnormalities
По данным
and frequently
главного
associated with
дерматовенеролога
systemic
Республики Беларусь
symptoms.
Анны Павловны
According to
Музыченко,
the main
генодерматозами
dermatovenerologist,
страдают
Svetlana
пациенты
Muzyczenko,
12 случаев
these
на 100 тысяч
dermatoses
населения, ихтиозом
have
9,5
prevalence of
на 100
12
тысяч,
cases per
врожденным булезным
100,000 of
эпидермолизом
population,
1,3
ichthyosis,
случая на 100 тысяч населения.
and
С
other similar
2017
skin
года ведется
abnormalities.
учет этих
Starting from
заболеваний, этих пациентов,
2017,
и в
we
структуре
have
заболеваемости
been
клиническими
performing a
формами
registry of these
простой
patients, taking
простой
into
булезный
account the
эпидермолиз
clinical
занимает
forms. Simple
63%,
bullous
а возрастные
epidermolysis
категории
quantifies to
проявляют динамику
63%,
абсолютного
while for
количества
different age
увеличения
categories,
случаев
sometimes
врожденного
it is the
булезного
absolute
эпидермолиза
increase
буквально во
in the
всех
inborn
возрастных
bullous
группах. Что
epidermolysis
касается
in almost
ихтиоза, здесь
every
также в
age
каждой возрастной
groups.
группе,
As
то
for
есть до 17,
ichthyosis, in
18 и
every
старше
group
всего,
up to
имеет
18
место
years old
нарастание
and
абсолютного
older
количества
than 18
случаев
years old,
ихтиоза
we have an
среди
increasing
населения
trend of
Республики
absolute
Беларусь,
number of
и
ichthyosis
основной,
cases
конечно,
in
процент
Belarus,
составляет
and the
ихтиоз
main
простой.
percentage is
Тенденция к росту
simple
заболеваемости
ichthyosis.
врожденным ихтиозом
The
обусловлена
trend
не
to
только
growth of
истинным числом
inborn
роста случаев,
ichthyosis
но
is
и
not only
улучшением
due
качества
to better
специализированной
detection, but
медицинской
also
помощи,
the increase in the
доступности к
specialized medical
таких
care,
методов обследования, как
accessibility of these methods
диагностика,
of study,
автоматическое секвенирование для выявления
like
специфического
automated
генетического
sequencing
дефекта,
to identify
пренатальная диагностика во
specific
время
genetic
беременности,
breakdown,
ну а также
DNA,
медико-генетическое
diagnosis,
консультирование для
prenatal
верификации
diagnosis, as well as
диагноза, для
medical
оценки
genetic
риска рождения
consultations
детей
to
с
verify the
ихтиозом при
diagnosis and
последующих
evaluate the risk
беременностях.
of
На базе
birth
клинического
of
центра
a child with
дерматовенерологии в городе
ichthyosis.
Минске
Based on the
создан республиканский
dermatovenerological
кабинет
center in Minsk,
генетической
we
патологии кожи,
established a
который с
Republican
2017
office for
года
skin genetic
ведет
pathologies
банк
that,
данных о
starting from
пациентах с генетической
2017,
патологией
has been
кожи.
performing a data
Соответственно,
bank
оказывается
for skin
специализированная
pathology patients.
дерматовенерологическая помощь пациентам,
Specialized
консультативная
dermatovenerological
помощь
care is provided,
врачам-специалистам. Также для помощи
advisory
этим пациентам
medical
и
care,
специалистам
and
создан
also to
клинический
help these
протокол
patients.
диагностика
There
и
is a
лечения
clinical
пациентов с
protocol
врожденным
for the
буллозным
diagnosis and
эпидермолизом.
treatment of the patients with
Также создана
inborn
школа
bullosis
для
epidermolysis,
пациентов с
as well
врожденным
as a
буллозным
school
эпидермолизом в амбулаторных учреждениях
for
здравоохранения.
patients
Для
with
пациентов
inborn bullous
также изданы
epidermolysis.
методические рекомендации.
Also, there
Нужно
are
сказать, что для того, чтобы пациенты
methodological
имели
guidelines
доступ
for
к бесплатному
patients,
или
for
льготному
patients to
лекарственному
have access to
обеспечению
free
и
of charge
обеспечению
drugs,
перевязочным материалом,
and
было
also
необходимо включение
dressings
этих
material.
заболеваний,
It is
врожденного ихтиоза,
necessary
буллозного
to
эпидермолиза,
include these
в постановление Совета
diseases
министров.
in
На
appropriate decrees
основании,
of the
так
Council of
сказать, этого
Ministers.
решения сегодня
Based on
предоставляется
this
бесплатное
decision,
обеспечение лекарственными
free of
препаратами
charge
для
medical
обработки
care is
раневой
provided
поверхности у этих
today
пациентов и
to
перевязочные
care for the
материалы они
wounded
получают со
surface, as
скидкой
well as dressings
90%.
material
То есть
with
здесь
a discount of
показаны
90%.
республиканские
So
формуляры, перечень
here you
основных
can see
лекарственных
the
средств, куда
Republican
включены,
formularies
соответственно,
of the
лекарства для
main
бесплатного обеспечения
drugs,
и
which
перевязочный
include
материал.
drugs
Для
for free
пациентов
of
с
charge
ихтиозом это также
provision, as
бесплатное
well as
обеспечение
dressings
лекарственными
material. For
средствами, которые
ichthyosis
включены
patients,
и
it's
в
also about
республиканский
free of
формуляр
charge
26
provision of the
года и
drugs
в
that are
перечень
included
основных
in the
лекарственных средств
Republican formulary
2026
of
года. Кроме
2026
того, в
and the
2017
list of
году была
essential
подписана
drugs
программа
of the
«Помощь
same
детям с
year.
буллозным
Also, we signed
эпидермолизом»
a program
Министерством
for the
здравоохранения
medical
Республики
care for
Беларусь и
children with
Международным
bullous epidermolysis.
благотворительным фондом помощи детям «Шанс». Эта программа
Thanks
позволяет
to the
обеспечивать
charity
ряд детей с
foundation
буллозным
called
эпидермолизом
Chance,
необходимыми
which helps to
лекарствами,
provide a number of children
обеспечение
with bullous
более реальной
epidermolysis with
возможности
the
проведения
necessary drugs,
генетических
to provide a
исследований
real
и
possibility
информационной
for genetic
поддержки.
testing and
В
provide
перечень заболеваний Совета
information
министров,
support.
который дает право на
The list
льготное
of the drugs
обеспечение,
of the
также
Council of
впервые в
Ministers that
2026
provides
году
the
было
right
включено
for
заболевание
preferential drug
лимф-ангиолемиоматоз
access,
легких.
also
Это
included
редкое полиангиомиоматозное
lymphangiomatosis of the
заболевание,
lungs.
которое
This is a
поражает
rare
женщин
orphan
детородного
polysystemic
возраста
disease
и может возникать как спорадически, так и в
found
сочетании
mainly
с
in
туберкулезным
women of
склерозом.
reproductive
Это
age that
опухолеподобное разрастание гладкомышечных клеток
can
по ходу
come
мелких бронхов,
either
бронхиол, кровеносных
sporadically
и
or together with
лимфатических сосудов
tuberculosis
с
sclerosis.
трансформацией
This is
легочной
a
паренхимы, то есть
tumor-like
она
growth
замещается
of
кистами. И это приводит к
striated
рецидивирующему
muscular
пневмотораксу, дыхательной недостаточности. В этих
cells
пациентах также
in
наблюдается
small
лимфатическое
bronchi,
поражение грудной
bronchioles,
клетки,
and
брюшной
lymphatic
полости таза,
vessels.
ангиомиолипомы почек.
Sometimes
Нужно
it can
сказать, что
be
этиология
manifested by
окончательно
kidney
неизвестна. В патогенезе
angiomyolipoma.
ведущую роль
Etiology is
относят
not
эндокринным
finally
нарушениям.
established.
Наблюдают
Endocrinic disorders are
преимущественно у
suspected.
женщин, как правило, в
And
детородном
mainly it
возрасте,
is
с усилением
women,
дыхательной
usually in
недостаточности во время
reproductive age, with
беременности и
increase
менструации.
of the
Заболевание может
insufficiency of lungs
замедляться в
during
своем
pregnancy
прогрессировании
or
после
menstruation.
наступления
Sometimes it
менопаузы.
can have a
Начало
slower
болезни может
pace
быть
after the
спровоцировано, наоборот, лечение
menopause, or
эстрогенами. И прогноз в
treatment with
большинстве
estrogens
случаев, нужно
can
сказать, для
rather
мам
provoke the
достаточно
onset of the
неблагоприятный.
disease,
Медленно,
and
но
the
болезнь все-таки
prognosis
прогрессирует.
is
И,
quite
конечно, летальный
unfavorable.
исход
It
может
progresses slowly but steadily, and
также реален. Десятилетняя
it can
выживаемость
even
составляет
lead
от
to death.
10
10
до
years survival is
60%.
about
Поскольку основное
from 10 to
проявление дыхательной
60%.
недостаточности,
Since
одышка,
the main
бронхообструктивный синдром
manifestation
и
is
рецидивирующий пневмоторакс, ксилоторакс,
bronchoobstructive
кровохарканье и
syndrome
кашель,
and
для диагностики, в
coughing,
общем-то, есть ряд, так сказать,
sometimes with
препятствий
blood.
в виде необходимости
There is a
дифференциального
number of
диагноза.
barriers to
Диагноз вам
diagnosis in the
устанавливается в
area
течение
of
месяцев и лет
differential
после появления
diagnosis.
первых
This
признаков
diagnosis
заболевания.
usually takes
В соответствии
months
с
or years
международными
to be set
консенсусами
after the
сегодня
first
обязательными
signs
являются КТ
of
высокого разрешения в
manifestations appear.
диагностике, ну а
ECT of
также КТ
high
органов брюшной полости малого
resolution,
таза в
CT of
условиях
high
костного
resolution is
перенного
mandatory
контрастирования
today
также
for lungs
является
and pelvis.
обязательным.
With contrast, it is
Диагноз вам может быть
mandatory.
установлен на
Visualization interpretation method. This diagnosis can be set based on a typical CT findings or one of the signs and manifestation is the location of lymph nodes. According to guidelines of US and Japanese respiratory societies, it was established that glucocorticoids, radiation therapies that were used before, tamoxifen and androgens and gonadotropins do not have evidence-based. Moreover, the estrogen-containing drugs, those that include contraceptives, are absolutely counterindicated. Genetic molecular mechanisms were established treatment strategy. First of all, mTOR inhibitors and also matrix metalloproteinases, aromatase inhibitors, cycle-independent kinase inhibitors, and so on. Understanding of the main mechanisms for this disease identified the central role of the signal pathways of rapamycin in mammals and mTOR. So today the method of treatment of lung manifestations is sirolimus and everolimus, the second generation of mTOR inhibitors. At the critical stage with total involvement of lungs and severe respiratory insufficiency, lung transplantation is the only solution. Sirolimus and everolimus treatment is associated with better lung function, better life quality, better stability of the patient's condition, and in terms of safety and adverse reaction of everolimus and sirolimus, they are, well, quite in line with each other, and the most frequent is stomatitis, nasopharyngitis, headache, and hypercholesterolemia. In Belarus, there is no, strictly speaking, registry of these patients, but based on one of the institutions, we established a centralized information system for observation of these patients. Today we have registered 22 patients with verified diagnosis aged from 32 to 62. And for them, mTOR inhibitors is, of course, off-label because there are no direct indications for these drugs. There is a decision from the Republican Medical Consilium. So 19 patients are receiving pathogenetic therapy with everolimus in individual dose under control of the concentration in blood serum.
Третьи-десятые сутки при стабильности
состояния
через 2 недели, а затем амбулаторно 1 раз в месяц, 1 раз в 1-2 месяца. Средняя суточная доза эверолимуса, в общем-то, имеет достаточно такой широкий предел, от 4,5 до 15 мг в сутки в этой выборке, по данным главного пульмонолога нашей страны, Давыдовской Елены Игнатьевны. Средняя длительность титрования вне дозы до получения терапевтической концентрации в среднем составляет от 2 до 3 месяцев. Среди этих женщины были подвергнуты трансплантации легких, успешной трансплантации, были проведены и все эти 3 пациентки продолжают получать терапию эверолимусом, подобранной затем дозе. И только 3 пациентки не получают фармакотерапию, 1 самостоятельно отказалась от терапии, и 2 находятся под наблюдением постменопаузальной женщины в состоянии стабильное.
They are under follow-up. In terms of safety evaluations, there is no data about serious unfavorable adverse events. To make this drug more affordable to patients with this diagnosis, in 2026 we included these drugs, everolimus 5 mg pills, in the list of mandatory drugs for indications based on the multidisciplinary board indications. So there is a general global trend of increased number of orphan or rare diseases and people suffering from these diseases. The criticality of this is only increasing. In our country, there is 151 disease of this, according to the classification of our Ministry of Health. However, the number of such patients can be much higher. So, improvement of diagnosis enables identification of greater number of patients in our country. But since it is a chronic disease and they require almost lifelong pharmacotherapy, one of the main problems during the treatment is the cost of the treatment. Sometimes it is way too high for the patients. They cannot afford it. So in our country, taking into account the specifics and financial resources, the level of development of pharmaceutical industry, we have developed very effective approaches. However, the optimum model of the regulation today requires still some further work through. However, efficient ways out, ways forward, strongly depend on the efforts of the professional community, interaction between all stakeholders, and the general objective for optimization of our efforts for patients with orphan diseases. Thank you very much for your attention, and also for this opportunity to take part in the third Orphan Forum of CIS countries. I wish you strong health, success in everything. Thank you very much, Larissa. Amazing presentation as usual. And now we are moving further along our agenda. And let me give the floor to Albert Martirosyan, President of the Armenian Association of Specialists in Evidence-Based Medicine. The presentation title is Use of Data in Rare Disease Settings. Thank you very much, Alexei. The subject of my presentation is specific features of the use of RWE, RWD for rare disease clinical studies. We listened to many presentations about registries, about observational studies, and this presentation actually summarizes the examples of the registries in the settings of orphan diseases. The definition is, well, the natural course of the disease is disease progress in the absence of treatment until it is cured or until the death of the patient. The studies of the natural course of the disease is a planned observational study with the purpose to follow up the course of the disease, during certain time we can follow up a group of people who either have the disease or the risk to have the disease onset. The purpose of the study is to identify demographic and genetic features. The use of this method study the natural course of the disease. First of all, the registries are frequently used as platform for data collection to study the natural course of the disease, but in their turn, these data from the natural course study actually enrich and beneficiate the real-world evidence data, and they put together new registers. They participate in shaping of new registers. The natural course of the disease observation can identify key events or identify important physiological changes that are important predictors of the disease progress or have clinical significance just by themselves. To identify which subgroups of patients can benefit from specific clinical study, evaluate ability of either new or existing system of evaluation of clinical results, clinical outcomes, to identify changes in a specific disease or the patterns of progress in this disease, evaluate efficacy and reproducibility of this evaluation system, identify or develop biomarkers that can serve as diagnostic markers for the disease, provide forecasts for the course of the disease, or be useful when patients are selected and dosage is selected in the program of drug development, to provide possibility to collect samples or images that might be used in the analytical validation program. After reliable validation, these biomarkers can serve as a true endpoint or surrogate endpoint in clinical studies. It is useful to understand how certain subgroups can benefit from specific clinical study, to provide a non-treated external control group as a comparator for the treatment group for the drug. On last week, actually, we had a conference with FDA according to these external control problematics, and we studied a number of drugs there for orphan diseases. Next objective is to evaluate the value for rare disease patients, establishing special communication channels, designating specialized centers for specific disease to contribute to better understanding and evaluation of the standards of care. And finally, to provide demographic data and epidemiological evaluations of the disease prevalence and its characteristics, as well as to help in following up the disease prevalence. What kind of natural course studies are available? Natural history study. There are retrospective and prospective study, longitudinal and transverse studies as well. So what we can get from transverse studies, we can understand the general course of a specific disease by sampling from a cohort of patients at various stages of the disease. We can provide description of the diagnosis, disease severity, and also methods to evaluate. They can also provide information for the therapy, to provide benefits of immediate effect for acute episode patients. A shortcoming of this design is a very short period of the data collection. Next, we have longitudinal studies that can give us full information about onset and progress of the disease, and usually are the best method of choice to designate specific subgroups of the disease, especially if the disease has an unpredictable course. Can be useful to identify prognostic factors, for example, to distinguish between rapidly progressing or slowly progressing diseases for a rare disease. The drawback is duration. Let me tell you that according to the data of EAM from the US, there are prospective studies for orphan diseases that will be presenting data in 2028. The key moments that I would like to highlight here are that recently growth of interest has been registered in the development of drugs for rare diseases, which will enable our developers to perform studies much cheaper at much lower cost than randomized clinical studies using external control groups. with this design of the study. What this can change? This will improve the informativeness of the study, and also what we can see now in rare diseases. We need to organize webinars and seminars more frequently, seminars about clinical studies, about this design of protocols and statistical analysis, and also to ensure good translations for the guidelines, because there is very little literature for rare diseases. Thank you for your attention. Thank you very much. It is a very important presentation. For me as a clinical pharmacologist, for me personally, it is a very important presentation about the methodology. At least you touched this problem of the methodology of studies for orphan drugs, for orphan conditions. They can be different, these approaches, and methodology approach might be different as well. We know, and interpretation might be different as well. Data might be interpreted in a very different way. For example, we know that last September, FDA issued a document where they suggest to have this methodology of evidence-based medicine for orphan diseases. This is kind of new viewpoint at the evidence-based medicine. It appears that evidence-based medicine starts to be separated. Evidence-based medicine for orphan diseases, evidence-based medicine for gene, for cell therapy, for CRISP, for Cas9, its own evidence-based medicine, a very interesting evolution of evidence-based medicine. Thank you very much indeed, a very important presentation. Thanks to you. So, dear colleagues, we are moving forward. We are moving very well according to our agenda. Thanks to the speakers for sticking to the timeline. And our next presentation is done by Polina Mukhortova from the Expertise Center, Moscow, Russia. Thank you very much, Alexei. Can you see my slides? Not really. Let's wait. And now, yes, now they're here. So, dear colleagues, today I would like to tell you about preliminary results of our pilot projects on data collection about the changes in the condition of children who are receiving therapy from the Circle of Kindness. I am the main specialist of sociology support for the Center for Quality Control of the Ministry of Health of Russia. And let me start with saying that today in Russia, at the supranational level, we have this concept of real-world clinical data about the health of the patient or medical care that we can get from different sources. And we can use this data at two levels. We can use the real-world evidence data at the patient level, therefore changing the treatment strategy, modifying therapy or adding some additional rehabilitation measures and so on. Or we can use it and interpret it at the population level and re-evaluate, reassess the drugs or other technologies based on the data that we have analyzed. And some colleagues mentioned this during the HTA session, especially our Chinese colleagues. They have huge experience in this area. And here we need to keep in mind that this is the data analysis at the population level. So for us to make this analysis, we need to select certain criteria for which real-world evidence will be collected for all patients in this population. If we want to generalized data of 1,000 patients, we need to be sure that the outcomes are similar, criteria are similar, and evaluation was done in every person. So that's the Expertise and Quality Control Center is the institution that performs this assessment in our Circle of Kindness Charity Foundation. So today we have developed the parameters for evaluation for 67 diseases from our list of diseases included here from 2021 to 2024. And the disease that was included in last year, for them, the parameters will be developed in this year. And here I'd like to stress that for these parameters in our expertise center, we are developing them together with the multi-profile clinical community. We are inviting leading experts for specific diseases and jointly develop the list of parameters for which we need to evaluate changes in the condition of health of children who are receiving this therapy. And today we have 257 parameters like that. Why do we need them? In fact, in Russia, as part of the Circle of Kindness Foundation, we have a commitment for data collection about the medical care provided that includes the clinical outcomes, treatment outcomes. It is a decree of our government number 555. So all these children who are currently receiving therapy from the foundation require data to be collected, the data about the changes in the condition of the child. Is it better? Is it worse? By how much? And so on. So currently we are working on making sure that this data is collected according to certain parameters to be able to generalize them afterwards. So to improve the quality of data collection and analysis, this year we made a pilot project. For this pilot project, we selected 3 diseases: mucoviscidosis, SMA, and Duchenne's muscular dystrophy. Why we selected these? Because for all of them, there is a number of different therapies reimbursed by the Circle of Kindness. And the second reason is the number of patients. These are some of the most prevalent rare diseases that we have. And the pilot project looked like that. First of all, updating the criteria with relevant experts, then data collection from the healthcare authorities in the subject regions and also from federal medical centers. And also now I would like to share with you the results of preliminary data analysis. For our colleagues who are listening us from abroad, from other countries, internationally, I'd like to explain our criteria. Here we can see in some part the criteria in the change of Duchenne patients. Also here we have a certain name of the criteria. What do we need to evaluate? There is a unit of measurement for scales. Its score for 6-minute walk test is the meters, the distance walked, FEV1 and FC, its percentage, and so on. And so there are certain reference values. Reference values are needed for us to understand the change that we observe in this child. Does it fit into certain range? Or does it mean that this therapy actually brought to worsening of clinical results? I don't have a very big surface area on the slide, but there is one more column left. For which group do we apply certain criteria? If clinicians are listening to me, probably you know that the North Star score is not possible in patients who can no longer walk. So this score is only done in outpatient patients, those who still can walk, and similar for 6-minute walk test. Also, for some criteria, we cannot perform it in very small children. So we need to take this into account, and we need to understand that for each criteria, there are certain limits for what kind of patients these criteria are applicable. And now what we have is the result from 51 subjects of the Russian Federation, more than 1,000 patients with cystic fibrosis, Duchenne's dystrophy, and more than 200 patients with SMA. So altogether, the percentage of gaps is much smaller compared to previous project like that. For all diseases, we can evaluate the majority of the patients. So I will briefly share the results with you for you to understand how we came up with the results, and then I will give you the general approach. First of all, it was depersonalized data that we used. We took into account the best result achieved over a period. If there are 24 months after the onset of the therapy, if there is no effect according to criteria, but 36 months after the patient did achieve these results, then we took the better results. And on the previous slide, you saw that there are 3 parameters that evaluate patients' mobility: the North Star evaluation, full evaluation, and 6-minute walk. So generally, they evaluate how well can the child move. So this is the kind of parameters that we included here. So what do we get as a result? For 18% of the children, unfortunately, we were not able to make the evaluation for none of the categories, for any of the categories. Unfortunately, there are children for which data gaps are so huge that we were unable to understand, to make the evaluation. Secondly, we have a very low percentage of children for whom therapy is not efficient for all the categories for which we were receiving data. More than 50% of children for which data, all the data is good quality. And there is also a group of children where it was even more efficient for some specific criteria. So for this group of patients, for the 2% of patients, we have a diversity and mismatch in this category. If we merge 3 criteria in one category, if we see improvement in one criteria, but for the other criteria, we don't see the fitting for the reference values. There were only 2% of children like that, which means that this decision to split it this way is quite logical, and other children do not demonstrate such a high level of discrepancy. So I suggest we skip this slide. Here we can have a similar results for the drugs that we analyzed. I will only tell you that tablets and granules in the treatment of cystic fibrosis were analyzed separately. All the other drugs were analyzed according to their international non-patented names. So what can be our conclusions? First of all, we received more than 2,000 patient data from 51 different subjects of the Russian Federation, which enables us to say that the therapy is efficient. But unfortunately, for 18% of these patients, we cannot say anything with regard to the criteria for which we were collecting data, because the results of this pilot project were received by us based on manual data entry. Of course, we came across some manual errors or incorrect values. So this kind of mistakes will stay. We understand they will stay if we speak about manual data entry. To avoid this, we need to introduce some digitization in the system, and this work will be done in the future like that. And number 4, is that for some patients, unfortunately, we were not able to interpret the data because we were missing only one indicator, the initial value of the criteria. And this value cannot be found after the child started to receive therapy. So it is very important at the time when the child starts to receive therapy. Indeed, it is very important to fix this initial value because in the future, even if you have data for all other criteria, will not be able to interpret the result. That's it. I will be happy to answer your questions. Thank you very much, Paulina. I believe that your presentation initiated such a great number of questions, even among those who never heard it. I missed something in your presentation because you are going to publish your results, kind of article, yes, for us to get acquainted with it. And maybe at some other events you're also going to report it again, so it will not be the last time we hear that. But I have only one question. The protocol, did you make the retrospective analysis protocol? So here, I would say that it is not a post-registration study. It is not a study as such. We work on improving the quality and efficacy of data entry into a certain information system in the Circle of Kindness Foundation. So we cannot speak about the study protocol because it is not a post-registration study as such. And where did you get this data? From the registry, from the electronic history, or yes, it is depersonalized data. We received it from the Ministry of Health of the Russian Federation. Okay, and how did they collect the data? Well, I'm not the one to answer here, unfortunately. Okay, that's a very interesting story, extremely interesting and important story. What you are doing is just amazing. Everyone is expecting the time, the moment when somebody will undertake to tackle this enormous task. We are very grateful, but again, we need to discuss it in depth, how this data is collected, how we get this data, and so on. Thank you, thank you. Dear colleagues, we are moving to the next speaker, and the next speaker is Adlet Tabarov, Deputy to the Chairman of the Board of the National Research Center for Evolution of Healthcare, named after Salidat Kairbekova, Ministry of Health of Kazakhstan. And the subject of the presentation is the current situation with real-world data in Kazakhstan. Good afternoon, Alexei. Good afternoon, dear colleagues. You can see my slides, can't you? Yes, sure. So I want to present you the experience of Kazakhstan in conducting of real-world evidence and real-world data practice for the results of the clinical practice in rare disease patients. First of all, this question arose in 2020 when it was COVID pandemics, when nobody knew what kind of drugs can be used for the therapy. There were new treatment regimens, and nobody knew what kind of results might they bring about. So we started to use different schemes from WHO, from our scientists who came up with different therapy schematics. And in order to understand what is the real efficacy of these regimens, we started to collect data collect data about these regimens, these therapies. So at this slide, you can see that we have a number of rules, how we put together different lists in our drug formulary, the rules of healthcare technology assessment, the rules for review of clinical protocols, the rules for new diagnostic methods, and the rules for the list of orphan diseases. And the basis for all these rules is evidence medicine and healthcare technology assessment. But in these rules, there are only the classical levels of evidence and the studies that are mainly published in journals and research publications. But recently we started to use the data from real clinical evidence to make HTA assessment, or primarily to make the decision on the inclusion or non-inclusion of certain drugs in the formulary, specifically for orphan diseases. And different scales are used here, and we can use Oxford evidence scale, and the real-world evidence studies have a low level of evidence generally, but they do take into account the decision on the inclusion of the drugs in the orphan list. And it is important to note that the data that we have in our information system and a large database exists here in the electronic registry of inpatient patients, the acute coronary syndrome patients, cancer patients, pregnant women of fertile age. So almost all chronic diseases are included, including orphan diseases, for which we collect data for every specific patient as to when they were hospitalized, when they were released from hospital, with what outcome. And this data is very diverse, but currently our Ministry of Health is busy trying to unify it, to populate our information systems, to consolidate this kind of data, because the data of the patients come both from governmental or public information systems and private information systems. But the lack of commitment in the medical community, in the research community, when we speak about this database, because each patient has an individual code which is traceable in the information systems. If we take the studies that were performed in Kazakhstan, we analyzed it, well, we have registry of clinical studies, and we were searching only for the ones where real clinical evidence data were included. And starting from 2014, altogether 11 studies were performed in Kazakhstan, of which 4 were international, multi-center study, where Kazakhstan participated, and of them, out of 11 studies, only 2 were for orphan diseases. One was done in 2020. The results were reported at the Ethics Committee in 2024. The decision was made by the Commission accordingly, and secondly, in 2025, studies started to study the lupus erythemus treatment, a new drug to treat lupus erythemus. It was a new drug, so we are now analyzing data for this drug. So these are the studies that were completed in Kazakhstan recently, of which in 2020 we started some, but completed only some of them. And the experience of use of the real clinical evidence, real world data. Currently, we have, well, our Ministry of Health currently is collaborating with Kazakhstani institutions to perform huge work on putting together regulatory base. We have our new law, the code, the Healthy Healthcare System. That's the name. We can understand what is a database of real world data. It is based on real clinical practice, and on top of that, here are the results, the challenges for our clinicians, for them to perform proper work, to collect this data, to process the data. And this is a full-fledged integration. All data will be merged in one system, and appropriate infrastructure will be built. It's mostly registers for orphan diseases. Currently, we started to study lung diseases. Next will come a pool of qualified experts who will be busy with this practice. And of course, we will be continuing this work. And to be frank, not all the patients are ready to participate in these studies. And naturally, we are going to perform this work in every area. I'm done. I have a very short presentation today. Thank you for your attention. It's an excellent presentation. It's all very clear. And if you permit me, I will make just one comment. In your conclusions, you said that it is necessary to develop these documents, and these documents are actually under development. And this is maybe the only example that we have in the Eurasian Economic Union. We have documents for Eurasian Economic Union. We have the guideline document. We have the changes in the regulatory practice. And today, we are finalizing 3 more guideline documents. But all these documents, starting from the RWE, RWD concept, all the way to recommendation, which numbers 4, some guidelines have been already validated, and some other, the 3 others are expecting expertise. They all lack HTA assessment. And RWE, RWD, the republics, the countries, the regulators in these countries, the regulators will have to develop themselves this documentation, how to make HTA about the RWE analysis. We can see that it is a difficult process. We heard a presentation by David Danko, and we learned that the unified Europe evolutionary is further in the future progress than we are, and evolutionary they decided to make a unified, methodologically they opted for a unified HTA. So probably our countries that are part of the Eurasian Union today, or CIS countries, well, maybe they also want to make HTS independently, but looking at the experience of Europe, all this will end up in us having to discuss discuss a kind of unified document, how we should make health HTA assessment, analyzing real-world evidence data. And that's my opinion. Okay, thank you very much. That's a very important aspect that you highlighted. We are now having our final presentation in our session, Aida Zurdinova. And she is the chair of the Department of Clinical Pharmacology department in the Medical University of Kyrgyzstan Republic, and the subject is real accessibility of orphan drugs, a gap between registration and access. Yes, thank you. Good evening, dear colleagues. Thank you very much, Alexei, for this opportunity to speak here. I am happy to welcome all the colleagues at our forum. It is very important, and we have been discussing these issues in a similar way for many years, for third year running now. Of course, we have some consensus. We have our achievements in each of our countries, which is also a start for future development. And I manage the chair of clinical pharmacology department in the Kyrgyz Slavic University in Kyrgyzstan Republic, and I am a member of our working groups, multidisciplinary groups on development and adaptation of clinical guidelines in many rules. And as for HTA and evidence-based medicine and RWE, RWD, that provides such a direct link to the clinical pharmacology that we are trying to work here in this space and to follow the progress here. And my presentation will be built on the following 4 blocks. First of all, legal status, regulatory status of orphan drugs, the current landscape, and also current practice, clinical data, analysis of applications that we have, and prospects for the future. And of course, we have such a strong gap between registration and actual access to the drug, and the key problem is this gap between legal possibility to apply orphan drug and real medical aid for a specific patient. In Kyrgyzstan, recently we introduced a number of changes in our legislation. The law on handling of drugs was adopted in 2024 and amended in 2025. Automatic registration for orphan drugs based on registrations from FDA, EMA, and so on. And also in 2024, we introduced a new term, what an orphan drug means, but unfortunately there is no integration with the law on the health protection of Kyrgyzstan citizens. There is no definition of what is an orphan disease. But here we need to mention that, well, for orphan disease, we need to provide some kind of care, and therefore today we have prepared this document, the procedure for healthcare, medical care, and the procedure how we can identify whether it belongs to orphan drugs group or no, based on the prevalence indicator. And also we need to mention that to provide better accessibility of the drugs, we had this concept introduced in the law on the drugs, presence of a special list And back in August 2025, we introduced a special procedure how we shape together this list. It is possible to include the drugs that have not been registered in the country but are present in our national registry. And if it is registered but haven't been imported in our country in recent 6 months. So the first point in this document sets a priority for orphan drugs. A lot of questions about target therapy. It is also very costly, and sometimes it is quite difficult to designate it as an orphan drug or just a costly drug. So we simplified greatly the entrance procedure for our market, but on the other hand, we don't have a finalized list of orphan drugs yet. Before that, there was a list with about 110 drugs, but how frequently are they applied in our republic? We don't have the statistics. We don't have this registry. In the National Center for Protection of Motherhood and Childhood, as of today, we have only SMA registry, Gaucher, and Duchenne registries. And as for others, unfortunately, as of today, they are integrated in a database, but we don't have it so far. Because while we don't have this disease registered, we can't have an understanding of what we are buying. And if we take into account financial part, nominally figures are going up in economics, but if we take the share of healthcare spendings, unfortunately, it is going down. And at this rate, let's say that local budgets in the region actually allocate very, very moderate amounts, just next to nothing. And we are writing letters to the Ministry of Health to increase the budget at least by a little bit for orphan diseases. And this June, we are going to have some renewals here and well, maybe to get some financing here. But all the procurement for orphan drugs, they are part of the group of financing of, let's say, as part of financing of the High Technology Foundation. This is allocated by the Ministry of Health to develop some high technology interventions, let's call it like that. And orphan drugs fits to this group. They fit to this group. And we only purchase it in a centralized manner through Kyrgyz pharmacy company. So the otherwise other ways are not available for the drugs to become accessible in our regions, in our country. So money, how money is spent. And every year we perform analysis of this data. Here we can track how money was spent, and we have applications from 12 organizations, applications for financing, and this table actually indicates the proportion, and the total share was more than 10 billion. But in this case, this ABCVN analysis actually enabled us to perform it, and we actually can understand what we can get from there. So we achieved drugs from the first category of costs, those that are most important, and this amount cannot be financially allocated in full, only to 2.4 billion. So we had to change some items, some positions of some drugs here. And also another category was for orphan diseases in the general procurement. But I will show you how much do they undertake. And we have only a limited number of organizations who are receiving funding for orphan drugs. So here, of the first category of costs, the E category, essential, includes the drugs that are included in the clinical guidelines, but due to some reasons were not included on the national list of pharmaceuticals. But this is part of every healthcare organization. So this analysis has shown, now we are reviewing this national list, and next week we are going to have a discussion for it. So recommendations were issued to consider these AEAN categories, to be able to include them on the list, but list of essential drugs. But also this year we decided not to create a specific and separated list of orphan devices to include them on the list, but rather indicate, make an indication that it is an orphan drug. Because when applications were received, we saw how much was the share of these drugs. Of course, we have some organizations that focused mostly on drugs, others focused mostly on medical devices. All this depends on the specific organization that is receiving this for the allocated finance. Our spendings in 2024 and 25 were similar. I would like to give one example of risdiplam medicine. 80% of the spendings, roughly speaking, was spent on one drug only, risdiplam. Only the B category was for emicizumab, and applications for 2026. The application for emicizumab procurement is almost 4 times higher. Yes, risdiplam is being procured, but it was not included on the list of essential drugs, but it is included in the list of additional drugs from the Center for Protection of Motherhood and Childhood. So here we refer to international guidelines, which is quite permissible. And for 2026, here you can see the statistics of applications for orphan drugs. We have new 5 Gaucher patients in our registry. So they included glucocerebrosidase enzyme replacement therapy. So far for risdiplam, financing is allocated for 25 children only, but now we have 49 children like that. So only 26 children today can receive this amount of money, and the others, for others, we have a problem. And they are complaining why 26 children are able to receive it while the others cannot have it. So a huge growth, which means better diagnosis. But on the other hand, speaking about genetic labs, they are all private, and also they don't make analysis here. They send it abroad, either to Russia or to Kazakhstan or to Uzbekistan. We don't have our own lab, which increases costs for the patient and also highlights the need for having at least one laboratory, be it even private, but to make the analysis here in our country. And the most important conclusions. Still, we have developed the regulatory basis, the mechanisms, but we don't have confidence that every patient will be able to receive the therapy because financing is not enough to cover all the needs. And the first problem that we can identify is presence of such a lab, is ability to maintain a clear registry of patients, a clear list of rare diseases for which we can buy high technology drugs. However, today we made an application to separate to have a special separated budget for orphan drugs, orphan diseases specifically. Also, introduction of a special item for orphan diseases to provide drugs for even for those 26 drugs. We had to cut down budgets of some organizations to be able to buy risdiplam for the 26 children and my expert opinion that it is possible to launch a joint Eurasian Orphan Foundation, a unified organization like in the European Union for all the territory of our macro region. Maybe price will be lower because of that, and well, we will be making some kind of mutual efforts, maybe eliminating duplication somewhere, which will streamline the whole process. So maybe our work should be focused here. That's all I wanted to say. So I tried to squeeze as much as I could, be as short as I could. It's tremendous. You really fit into the agenda. Thank you ever so much indeed. I have a quick question. You showed SOM currency, the amounts of money that you showed. What kind of currency? For the ABCVN analysis, SOM, it is in SOM, the Kyrgyzstan currency. To Russian ruble, it's like 0.1, 0.8, 0.9. Thank you very much. Dear colleagues, taking into account time, let me move to the final conclusion. We have listened to all the presentation. Everything has happened. We had 7 presentations, and all the presentations were focused at the title of our session, RWE, RWD. So what we can see today, brief conclusion number 1 can be that there is a global trend towards progress in regulatory issues and understanding that RWE, RWD is necessary for different orphan conditions because of the epidemiology of these diseases, because of the diagnosis, and all the way up to development studies of efficacy and safety of these drugs, including HTA. Second conclusion. Strategy of our countries in the area of healthcare and development of information communication technologies in the healthcare systems results in a significant growth of the number of data sources for real world data. To make RWD become evidence, to become RWE, quality should be assured through proper regulation, single reproducible technology for all the participants, and development of quality standards and education for all stakeholders. We didn't say almost anything about patients, but patients should also be familiar with this concept. Of course, we need to inform them about that. And last but not least, we hope that the conclusion of our session will become part of the final resolution of the forum. And now let me give the final floor for the final contribution. We have the last session today. Our session is the last. No one will follow us. We are closing our forum today, so I would like to give the floor to the organizer of the forum, the Executive Director of the Orphan Consortium of CIS countries, to Nuria Musina. Dr. Musina, are you here with us? Yes. Yes, dear colleagues, good afternoon, and thank you very much, dear Dr. Alexey, because you are working with us every year, and together we are organizing these events. It has been a very interesting session. This year we had to split because we also have partners from BRICS countries, so that's why we sort of transform this session. It has become not only RWD, RWE, but also kind of HTA session. And number 1, what we currently need is to attach greater efforts to managed entry contracts, if we were able to make this kind of agreements, we might have become more efficient and maybe to have a higher quality data of real world data. Not what our colleagues have shown to us, because this kind of data is very difficult to use as evidence. So maybe when it is as part of these agreements, then it will be the warranty for the quality of the data. And of course, Circle of Kindness is this site where everything should be organized. It should be the real hub in this controllable access, similar to what David said today, all the foundations, the Innovations Foundation in Italy and others. Mainly, their mechanism is a managed access agreement. And also, as I heard what Professor Zurdinova said, some ability at least to negotiate pricing jointly. Of course, in Russia, we have different capabilities. On one hand, on the other hand, there are countries like Kyrgyzstan and Kazakhstan and Uzbekistan. If we joined our efforts in this process, maybe we would be able to have greater volumes, maybe not saving money, but at least expand the coverage and be able to care for more patients. And I fully agree with Alexei when he says that maybe in the future, similarly to European Union, we will follow this convergence methodology pathway, because today, indeed, we have a joint registration in Eurasian Union, and the next logical step is to make joint clinical assessment similarly to European Union, because it's quite clear that in Kyrgyzstan, there is no possibility maybe to assess every drug, and for clinical data at least we might share the data and eliminate duplication, because clinics is the same everywhere. So maybe in the future we will come to this joint clinical assessment, because it's well understood that budgets are different in different countries, and in reality it might be different. So that's the conclusion for today's session, for this session. Altogether, I'm very thankful to all the participants of the forum, because I believe that in recent years, this is an international event in CIS landscape, which is really the biggest. More than 30 countries participated. And if we look at our sessions, it was such a diverse national scope and composition, not only CIS, but also BRICS countries, MENA countries. And I'm very happy that we are able to create these bridges, that people start to get to know each other. And I believe it is very important, because the worst thing that might happen is when experts start to sort of be separated from others and live in their own fenced world. We should never reinvent the wheel. We should use the experience of some other countries if we understand that they have already passed through this experience and they have already something to share. So we need to talk to each other, to make international publications, to read publications. And I'm very happy to see that based on the results of the previous forum, we were able, based on our resolution, to make a publication in BRICS Health Journal, and in fact this became our position statement. If it is possible, if you have open access, you can read this article. It is in English, and Rare Disease International also joined it, and many colleagues wrote to me saying that we have read your publications and we have really similar area of activity. In fact, the same that we believe the cornerstone and how we want to develop in the future. What additions are we going to have this year? We will mandatorily make the resolution. Well, with your session, for your session, you can send us several key points, your suggestions for the final resolution of the sessions where I participated. Well, first is that yes, we decided that we'll be moving towards BRICS landscape because of the tremendous potential, speaking about drug access. And also we should coordinate our developments of orphan drugs and then take all this life cycle of the drug. It is an excellent substrate for BRICS countries because of the huge potential for improvement of the efficiency of all the processes, let alone experience exchange, data exchange. I'm speaking strictly about the economics. We understand that BRICS works very well on the economics turf. So this is a very good economic substrate for us. We just need to learn more, to submerge ourselves more here and to come up with some elementary rules and to think how we could help each other here, because we have a giant population. And of course, we can provide them with our resources. You see what is going on worldwide in the US, in Europe with the drugs. This is the kind of policy that they are implementing in the US, the most favored nation policy, you know. So currently we are seeing that accessibility of drugs in Europe is changing. And what we mentioned today, that procurement of drugs models are changing. The model is bound to change, and in the nearest future we are going to have Chinese drugs actually displacing Western drugs. The world is changing, so we need to build the kind of model here which would be convenient for our patients, accessible for our patients. So we need to make sure it's high time for us to develop some kind of joint policy here. So our efforts of our orphan consortium is toward BRICS countries, and the next objective is gene and cell therapy, improving access to gene and cell therapy in our countries. Unfortunately, now these technologies is absolutely inaccessible for most of our countries, and many people are thinking today how to make it accessible. There are many academic developments. It is no more rocket science, but it's very expensive. So what we see is an application of our networking, application for our expertise to be able to try to make gene therapy more affordable, to search for developments, to establish contacts with potential investors in these areas. So this is what are the new things that appeared here based on the results of our work during this forum. I'm very happy that thanks to this online format, we managed to work with our colleagues from different countries. And of course, now I was thinking about the previous forum. What we are lacking is personal meetings, and for the next forum we will think about where to organize it, either in Russia or in some BRICS countries. So we will be discussing this with consortium. The period of Tamara Aripova vice presidentship has expired now. Now we are going to select a new vice president. So we will see from which country this new vice president will be coming from. So we will be discussing inside our consortium the plans for next Orphan Forum of those who would want to host it. We are open to any suggestions, and we are also open to all the participants of our consortium. Maybe the next phase will be some kind of reformatting of this work, because we will reach the BRICS level, because we see greater potential here in terms of the healthcare policy. Maybe I will not be mistaken if I will say that we are working on healthcare policy. Yes, we do have these clinical areas, but here we are as a platform for networking from the clinical viewpoint. But still, I think our better role and place would be in all these organizations that are currently present in the area of rare disease, and we are health policy and international collaboration in health policy. Thank you very much indeed, and I would like to thank the people without whom our forum would not have been impossible. The girls who were helping us, especially Margarita, whom you know very well, that's for sure, who was personally guiding every one of you. And it actually turned out very successfully without any technicalities, issues. Thanks to everyone, those who was helping us. Thank you ever so much indeed. Please excuse me if I missed somebody, but altogether, I believe it's been very successful. So please write to me. You can write to me directly. My electronic email is available with any kind of proposals. From every session moderator, I'm expecting the proposals for the resolution. The resolution will be distributed to all the speakers for their approval. Thank you very much indeed.